So chest pain uh, is a syndrome. It can be due to many uh, cardiovascular, respiratory, musculoskeletal, or gastrointestinal causes. We will cover acute chest pain, which is acute coronary syndrome, ST elevated myocardial infarction, non-ST elevated myocardial infarction, aortic dissection, pericarditis, cardiac tamponade, myocarditis, stable angina, vasospastic angina, unstable angina, stable angina. All of them are causes of cardiovascular causes of chest pain. We will cover them. We will cover all of them. Tonight we will cover acute coronary syndrome, which is ST elevated MI and non-ST elevated MI. So acute chest pain, as we said before, it's a symptom. It's not a diagnosis. So we have to find the cause. But in MCCQ1, the priority is to identify the life-threatening causes. First, we will focus on life-threatening. As we talked in the previous lecture, we have to think about differential diagnosis. Have three parts, One must not miss diagnosis, then the common ones, then the rare ones. So the first one in acute chest pain, we should focus on life-threatening causes like acute coronary syndrome. And because it's important because it's a time-critical emergency. We don't have we should not waste time on life-threatening causes. For example, we should not wait for cardiac enzymes when the patient has an ECG and an ST elevated ECG, and we know that the patient has an MI. We should not wait for confirmation for troponin. We should send the patient for PCI. So etiologies of the acute chest pain can be emergency, life-threatening, and also can be non-emergency. In emergency, the cardiac can be acute coronary syndrome, aortic dissection. Pulmonary can be pulmonary embolism, tension pneumothorax, and pneumonia, and also gastrointestinal like gastroesophageal rupture and perforation. And non-emergency cause of acute chest pain can be cardiac, stable angina, and can be other non-ischemic causes of the cardiac causes like pericarditis. Pulmonary can be pleuritis, can be mild asthma. Exacerbation in gastrointestinal system can be reflux or esophageal spasm, gastritis. They all can give chest pain similar to ischemic heart disease. Musculoskeletal like costochondritis, muscle strain, rib fracture, all of them give acute chest pain, but they are not as emergency as acute coronary syndrome. And also psychogenic like anxiety and panic disorder, they also can cause chest pain. They should be in mind when we talk about our differential diagnosis. So the first topic is acute coronary syndrome. It's an umbrella term. It is for unstable angina, non-ST elevated MI, and ST elevated MI. And it has two types, type A, type 1, type 2. Type 1 is due to plaque rupture or erosion inside the artery, inside the coronary artery. And because of that, there is platelet adhesion, then activation, then aggravation, and coagulation cascade, and thrombus formation, and then the artery is blocked. If the artery is completely blocked, it causes ST elevated MI. It causes transmural ischemia, and because of that, in ECG we see an ST elevated MI. If it's partial or intermittent, so the necrosis is subendocardial, then it's non-ST elevated MI in ECG, and the troponins are negative at first, and then they become positive. And also, another cause can be supply-demand mismatch. For example, there is high demand of oxygen, like in tachyarrhythmias or hypertension, or low supply of oxygen, like hypotension, anemia, or vasospasm. In type 2, there is no plaque rupture, but still there is ischemia of the heart muscle. Other causes can be coronary vasospasm due to, for example, cocaine can cause vasospasm, and coronary embolism, myocardial, and then the key thing in this is ST elevated MI means complete occlusion, and it needs urgent reperfusion. You have to open the artery. In non-ST elevated MI and unstable angina, then it's an incomplete occlusion. We have to risk stratify the patient. Then we can, yeah, for this, we have time for troponins, serial ECGs. Then we can decide about the management, what to do with the patient. But in ST elevated MI, we should not waste time for serial ECGs or cardiac enzymes. So in this table, we see the acute coronary syndrome classification. The subtypes are ST elevated MI, non-ST elevated MI, and unstable angina. And in ST elevated MI, we see there is a persistent ST elevation in ECG, and biomarkers are elevated, and there's complete occlusion. In non-ST elevated MI, then in ECG, we can see an ST depression, a T wave inversion, or no ECG change. Biomarkers are elevated in this non-ST elevated MI, and it shows a partial or intermittent occlusion. In unstable angina, there is transient or no ECG changes at all, and biomarkers are negative, and it shows a partial occlusion without necrosis. So the difference between unstable angina and non-ST elevated MI is that the biomarkers, the troponin level, in which in unstable angina, the troponin level is not elevated, it's normal, and there is no necrosis. ACE's clinical features include symptoms and signs. The symptoms are just discomfort at rest. The patient, although the patient is at rest, the patient has chest pain. And there are also other unspecific symptoms such as nausea, diaphoresis. There is one thing that should be in mind, and it's atypical presentations, which can be seen in women and elderly patients, and patients with diabetes. Sometimes they do not present just as a typical case. Diagnosis of acute coronary syndrome is done through electrocardiography. For the first test will be an electrocardiography when we suspect acute coronary syndrome, and it should be done immediately within 10 minutes of presentation. You shouldn't waste time. And electrocardiography helps us to distinguish between ST elevated MI, non-ST elevated MI. And this directs our management. Other tests are high sensitivity troponin assays, for especially for non-stable elevated MI. At first, it's negative or it's normal, then it's elevated. Because of the high sensitivity of troponin testing, the patients that were previously diagnosed as unstable angina, when we do the troponin test, they become ST elevated MI. They will be diagnosed as a non-ST elevated MI, which shows necrosis and requires more urgent management than unstable angina. And the management point, for example, for a stable elevated MI, it requires rapid reperfusion within 60 to 120 minutes, 1 or 2 hours. If it's not available, we should do the fibrinolytic pathway. And then we can do, if PCI is available within 24 hours, then first we do the fibrinolytic, then we send the patient for PCI or percutaneous intervention. And non-ST elevated, we have to risk stratify the patient, and then the patient can be sent for angiography and revascularization within 24 to 48 hours. But in STMI, we see that it's 1 to 2 hours. The patients need pharmacotherapy, like dual antiplatelet therapy, aspirin and clopidogrel, anticoagulation, statins, beta blockers, ARBs, or AC inhibitors. And also these patients need secondary prevention to prevent further heart attacks, like smoke cessation, like cardiac rehabilitation, lowering the lipid level, and things like that. So now we will separately study ST elevated MI and non-ST elevated MI. As we mentioned before, the ST elevated MI is a type or form of coronary syndrome, acute coronary syndrome, and it's due to plaque rupture and erosion and complete obstruction of the coronary artery. The key risk factors are older age, male sex, smoking, hypertension, diabetes, dyslipidemia, chronic kidney disease, and prior coronary artery disease. These are the most common risk factors. In MCCQ1, the most important thing about ST elevated MI is it's time sensitive ECG interpretation. ECG should be done within 10 minutes and it should be interpreted on time. And then because we have to decide about reperfusion. In the exam, they want us to recognize ST elevated MI immediately. And when we diagnose it or recognize it, then we can activate the STEMI elevated pathway. And we should avoid delays, which are dangerous. We shouldn't wait for biomarkers or any other testings to confirm it, because it's the elevated MI, ECG is enough for diagnosis. And ECG should be done within 10 minutes. And then when it's the elevated MI, we should send the patient for rapid reperfusion. Classic symptoms are severe pressure-like retrosternal chest pain radiating to the arm or jaw, shoulder, or back. It can be with dyspnea or without dyspnea. Diaphoresis is more common. Patient can have nausea, vomiting, or syncope. A typical presentation can be seen in women, older adults, and patients with diabetes, as we mentioned before. And the key physical exam finding is diaphoresis, pallor, tachycardia, hypotension, crackles, is for cardiac sound, in some patients pulmonary edema, or a new murmur. When there is a new murmur, there is a risk of papillary muscle rupture or wall rupture. The initial workup, when the patient presents with these symptoms, the initial workup is ECG, 12-lead ECG immediately within 10 minutes of arrival. You should manage that. And the patient should be put on continuous monitoring, establish IV access, repeat ECGs if the first one is non-diagnostic or has non-specific changes. But the suspicion remains. We have to do a serial ECGs. We can send troponin, but if there is the elevated MI, we should not wait for its result. We can send the blood for test, but we should not, if the ECG is diagnostic, we should not wait for that. When we say ST elevation, this is the normal ECG wave. As we see that this is the baseline, and this P wave, then QRS complex, then ST segment, and then T wave. It's normal. Everything is on the same line. But in ST elevation, we see that the ST segment is elevated, goes up. And this is a typical pattern of ST elevated MI in ECG. And in real ECG, we can see something like this. The differential diagnosis, the must not miss diagnosis are aortic dissection, pulmonary embolism, pneumothorax, pericarditis, and gastrointestinal reflux disease. For example, for aortic dissection, there's a tearing or back radiating pain, acute and very severe. And also, there is asymmetry in blood pressure in both arms. In pulmonary edema, there can be pleuritic or positional pain. Also in pericarditis, there is pleuritic pain. In pneumothorax, we know that the patient has severe dyspnea and pain on the affected site. And in gastrointestinal reflux disease, there are other gastrointestinal symptoms, and the patient doesn't have any other uh, cardiovascular signs. The management of non-elevated uh, myocardial infarction is divided into initial or acute management and the definitive treatment. The initial management is first we have to do the ABCs. We have to check if the patient can breathe, airway, breathing, and cardiovascular system. The patient, we should place an IV access, take a focus history, and an immediate ECG within 10 minutes. The patient is given aspirin 162 milligram. If there is no contraindication, the patient doesn't have any hypersensitivity or any other contraindication. Also, if there is no contraindication, we can give the patient nitroglycerin, 0.4 milligram sublingual, especially if the patient doesn't have any hypotension or has not taken any phosphodiesterase 5 inhibitor. Because if the patient has taken the phosphodiesterase 5 inhibitor, then it can aggravate the hypotension and the patient can go to cardiac shock or cardiogenic shock. If the patient is hypoxemic, we can give the patient oxygen. If the oxygen saturation is less than 90, we should give the patient oxygen. If the patient's oxygen is above 90, then the patient may not need oxygen. The definitive treatment for ST elevated MI is primary PCI or percutaneous intervention, especially when the facilities are available in the hospital. Door to balloon should be less than 90 minutes for direct PCI. Or if PCI is not available in the clinic or in the hospital, and it's available in less than 120 minutes time in another hospital, then the patient can be transferred to the hospital if the patient can get there in less than 2 hours. If PCI is not available within this time frame, then the other option is fibrinolysis within 30 minutes, and then followed by transfer to a pharmacoinvasive strategy to perform a rescue PCI within 24 to 48 hours. These are the main management points. When the coronary artery blockade is removed, then the patient can be given a dual antiplatelet therapy, anticoagulation, beta blockers, AC inhibitors or ARBs, and statins. They are given to reduce the recurrent events, to prevent further attacks. Supportive therapy is done through anticoagulants, antithrombotics, vasodilators for pain relief, like nitroglycerin, and reinfarction prevention. Some patients because of microvascular obstruction, uh, they will have no reflow even after successful percutaneous intervention. You do the percutaneous intervention, but there is no reflow to the heart muscle. And for those cases, intracoronary adenosine and calcium channel blockers are indicated. After reperfusion, uh, decision should be taken about multivessel disease, heart failure, and left ventricular thrombosis. They should be uh, considered. In this table, we see the reperfusion strategies in summary. In primary PCI, it should be done within 120 minutes, and this is the gold standard with lowest mortality risk. If PCI is delayed, it's not available or is delayed, we should go for fibrinolysis. When PCI is not available within 120 minutes. And there is pharmacoinvasive strategy, which is fibrinolysis plus routine PCI more than 2 hours later, within 24 to 48 hours. And it is safer than facilitated PCI. Facilitated PCI means that we give fibrinolysis immediately before PCI. Complications and prognosis of elevated MI, the common complications are arrhythmias, acute heart failure, cardiogenic shock, recurrent ischemia, and mechanical complications due to papillary muscle rupture or ventricular septal rupture or free wall rupture. The red flags that show deterioration are hypertension, pulmonary edema, altered mental status, persistent chest pain, uh, tachy or bradyarrhythmia, which is sustained, or development of a new murmur. And the new murmur is a sign of probable papillary muscle rupture or any other mechanical complication. And when we see these red flags, we have to do reassessment of the patient. After reperfusion, the patient needs secondary preventions like smoking cessation, lipid lowering, like BP and diabetes control. The patient should adhere to the medications and also cardiac rehabilitation. These are the classical, these are the high yield testing points for ST elevated MI, and the classical or case would be an older patient with risk factors of coronary artery disease. We saw the risk factors, uh, high blood pressure, diabetes, hyperlipidemia. The patient has crushing chest pain, diaphoresis, dyspnea, and ECG shows ST elevation in contagious leads. It's not in all all 12 leads. It's in contagious. For example, it can be in anterior wall related leads, can be on lateral wall, can be inferior. If you see ST elevation in all 12 leads, then it's most probable pericarditis, not an ST elevated MI. There are common answer traps in the options. They give, for example, troponin. If there is ST elevated MI, we should not wait for troponin. We should not wait for troponin for confirmation. If the patient is normal, the patient's oxygen is normal, then we should not give the patient oxygen routinely. If the patient has symptoms of aortic dissection, then we should not give the patient fibrinolytic. When ECG is diagnostic, we should not give the patient the cardiac markers. The next best step decision points, the common ones in the questions. If the ECG shows ST elevated MI, then active reperfusion immediately. It's not, we should not wait for any other test or any other investigation. If the patient is unstable, we should stabilize while patient is moved for reperfusion. If PCI cannot be delivered in time, in the time windows we saw in the previous table, then fibrinolysis if eligible, if there is no contraindication to that, then transfer the patient to a center where PCI is available. So ST elevated MI is an ECG diagnosis, and reperfusion is emergency. We have to treat first, then if the biomarkers come and confirm it, they can do that, but we should not waste time to wait for the biomarkers. This was the ST elevated MI. Now we will discuss non-ST elevated MI, then we practice the questions. Dr. Sarah, you had a question? You raised your hand?
Sorry, can you hear me now?
Now I hear you.
Okay. Doctor, in one of the slides, you were talking about combination of PCI plus fibrinolysin. What is the indication for using both of them together?
When we do not have PCI available in our hospital and we cannot send the patient within time frame, within 120 minutes to another center which has the PCI, we give the patient first fibrinolysis, then stabilize the patient and send the patient to rescue PCI. Fibrinolysis only is for patients is for the conditions where PCI is not available at all.
So
Because
can you see if,
we do the fibrinolysis and there is a risk
you know,
of occlusion.
Yeah, in the questions, how they ask for the third one, I mean pharmaco-invasive, both of them.
Yeah, we will see.
Using
Yeah,
fibrinolysis, yeah.
yeah, they will give you the condition. They will tell that if the PCI is available in the hospital, in another hospital within, for example, 120 minutes or within 24 hours, or if PCI is not available at all in the city. So when there is, we do not have PCI available, then we do only fibrinolysis. If we have PCI available, but not in the time frame, then we do the fibrinolysis first, stabilize the patient, then send the patient for rescue PCI because we have to prevent any further ischemic event.
Thank you.
Nicole Manga.
Yes, doctor. Thank
Yeah.
you for the first part for the presentation. It was okay. But I'm a bit worried with this primary PCI. What I know is that the target window is less than 90 minutes. That's what I've always read. So I don't know if this one is new.
Yeah, it's where door to. I will show you here. Uh,
Because
yeah.
I know that fibrinolysis with PCI, that's 120 minutes, but
Yes.
PCI alone
Yeah.
90.
Yes. Door to balloon is less than 90 minutes. Direct PCI. And when there is transfer needed, it's less than 120 minutes. Then, if timing is slow, we cannot send the patient there. Then we do the fibrinolysis. Then stabilize the patient, and then the patient is transferred for pharmacoinvasive study for rescue PCI. Especially when reperfusion fails. If we do the fibrinolysis, then the patient has uh, pain again.
Okay, doctor, but what is the
Yeah.
difference between this 90 minutes that you've written here and the other slide that says primary PCI for 120 minutes?
This is for the clinic where the clinic the PCI is available in the clinic when the patient first comes. And
Okay.
when the patient when the patient comes to a clinic and PCI is available in less than 120 minutes in another hospital, another clinic, then this is for that. This is for the
Okay.
transfer. When this is available, then we send the patient. We stabilize the patient and send the patient to the next clinic. When the clinic is less than 120 minutes or less than 2 hours away from the clinic. But
Please,
when
doctor, I'm
yeah,
I'm still not understanding because what I understand is that when you do fibrinolysis when the hospital is not near, so you do it for 30 minutes and hoping to get to the hospital within 90 minutes. The total is
no no no
120.
no no
Is
no
that it?
no 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 no.
Okay.
When the patient comes to the hospital, the hospital has PCI. We should do it in less than 90 minutes in our hospital.
Okay.
When the patient comes to our hospital, the patient has chest pain. We check the patient. We see that the patient has ST elevated in MI, and there is another hospital which is nearby, and when the ambulance can get there in less than 2 hours. We stabilize the patient. We send the patient to the next center. The next center is notified. They know they prepare their cath lab. When the patient receives, they receive the patient. They take the patient to the cath lab and perform the PCI. When we do the fibrinolysis, when PCI is not available, and we cannot do the PCI within this 120 minutes, the patient cannot be sent there. No hospital nearby, no PCI available in the hospital and any nearby hospital. So the patient, because we want to do the reperfusion. Reperfusion cannot be done with PCI, so we do the fibrinolysis. It's the second choice. The first choice is PCI. When PCI is not available and not available within the time frame, then we have to do the fibrinolysis, and the fibrinolysis should be done within 30 minutes in the hospital. Then we stabilize the patient and then we send the patient because we buy time with fibrinolysis for the patient. Then the patient is sent to another hospital within 24 to 48 hours. The other hospital can do the PCI. But before that, we should do the fibrinolysis because the patient has the occluded artery and we have to open it. If we cannot do it with PCI, you have to do it with another way, which is fibrinolysis. I hope I could explain it.
Okay, doctor, thank you so much.
You're welcome.
Excuse me, Dr. Weiss.
Yes.
So the gold standard time window for the primary PCI is less than 90 minutes?
In the hospital,
Yes.
in the primary hospital, in the first
Okay.
hospital when the
Yes.
patient comes.
Yes.
If it's available in less than 2 hours in another hospital, that we can transfer the patient, we first stabilize the patient and then transfer the patient to that center which has PCI, because we want. Because PCI is the gold standard. If it's available within 2 hours, we should provide this service to the patient. If it's not available within 2 hours, then we should go for fibrinolysis. And when the patient is stabilized, then we can send patient to another center which has PCI, and they can do the rescue PCI to the patient.
Okay, one last question. And does this timing counts from the time that the patient does arrive to the hospital, right?
Yes,
Okay,
door.
thank you.
From door to balloon. Door
Okay.
means the emergency door.
Yeah.
From door, when the patient comes, 10 minutes, ECG. Okay, and then when the patient is diagnosed, we should do because it's the management is time related. We have to manage the patient within the time frame, because if we delay, the cardiac necrosis will grow and complications can occur. Dr. Chibuzo?
Okay, yes. So, can you hear me? Can you hear me?
Yeah.
Yes. Okay, so I have two questions. The first is from the previous table, and then this one we're looking at. So, under the definitive treatment that we're looking at, this where it says fibrinolysis within 30 minutes, and then transfer for pharmacoinvasive therapy, rescue PCI. I was thinking rescue PCI is when we do fibrinolysis and it fails, the person still
Yes.
has pain. Okay, is that what it's talking about here?
Yeah.
Okay, then what of now back to that table where you start with the fibrinolysis first, and then you take the patient, yes, you take the patient for PCI. So it's called routine PCI. It's not going to be called rescue PCI
Yeah,
for this one.
we do fibrinolysis,
Mm-hmm.
then we do the PCI later.
Yeah, so it's called routine PCI here. But the
Yeah,
other one is rescue PCI.
yeah. Rescue,
Okay.
rescue PCI is when we do pharmacoinvasive, it means that we do both of them. Rescue means if the patient we do the fibrinolysis and it fails.
Mm-hmm.
Yeah. Well, one thing we do a very quick review. If we talk about each of them in detail, then it will take each of them will take more than 1 hour. So I made this very quick. It's a very quick review, and you should not just rely on this one. It's just to remember, to just remind you about something. The main thing is in the book. You have to review or study the book as well because there are a lot of more um, details in the book. We if we talk about them, then we will not catch the schedule. So we have to just uh, tell the main things and then the details and the other information is in the for example, if you study Toronto notes, you have to just go and see that information there as well. It's it's, uh, it's what all of us did because if we rely on these slides are very short, very concise, and they do not have all the details. I hope I explained it properly. So if there's no question, we can go to the other section, which is non-ST elevation MI or myocardial infarction. So non-ST elevated MI is also a subtype of acute coronary syndrome. And in this, we do not have an ST elevation on NCG. The risk factors are the same as ST elevated MI, but non-ST elevated is a bit more common than other types. And it's important because the first ECG may not be diagnostic. The patient has symptoms, we perform an ECG, a 12-lead ECG, and the ECG doesn't show any ST elevation, ST depression, anything. It can be normal. And because of that, we have to perform or we have to do ECG for the patient several times because it can change later. In ST elevated, when we take the ECG, most probably at the first time we can see the ST elevation. But in non-ST elevated, this is not the case. When there is the suspicion is still there, we have to do a serial ECGs, repeated. So in non-ST elevated MI, when there is no ST elevation, it doesn't mean that the patient doesn't have MI. And it's one of the most one of the important points in MCCK exam. When the patient has in the question, it says that the patient has these symptoms and has the risk factors, but the ECG is normal, then we should think about ordering serial ECGs and also troponins. And this patient should not be sent home. This patient should be admitted. The classical symptoms are quite similar to ST-elevated MI, the same retroesternal chest pain radiating to the arm or jaw or neck or shoulder or back, and diaphoresis, lightheadedness, nausea, vomiting. And the physical exam is also quite similar. But the only difference is the ECG doesn't show ST elevation. But in any case, anyway, any case with chest pain, which is suspected of acute coronary syndrome, the initial workup is the same. We should do the ECG immediately within 10 minutes and put the patient on monitor, establish IV access, and send the troponins. And in ECG, we see that there is a depression in ST segment. Here we see that in this lead, we see that the ST segment is depressed. In here, in here, in here. Confirmatory test for this condition is troponin. We should, and when the patient has ST depression and non-ST elevated MI, troponins can be given to the patient. We can confirm it through troponin, because in non-ST elevated MI, it's partial obstruction, it's not total obstruction. And the differential diagnosis can be ST elevated MI, aortic dissection, pulmonary edema, pneumothorax, pericarditis, reflux, musculoskeletal pain. And the main thing in this and the differential diagnosis is ECG pattern. ECG will help us distinguish ST elevated from non-ST elevated. Also troponins. Also the type of pain, pleuritic or positional pain, and tenderness for musculoskeletal pain, for example, hypoxia in pneumothorax, tearing back pain in aortic dissection, or pulse asymmetry in aortic dissection. So the management is a little bit different. Initial management is the same, but the definitive treatment is a little bit different, because in ST elevated MI, we have to send the patient directly to PCI. Should not waste time. But in non-ST elevated, we risk stratify the patient. And we can stratify the patient at immediate, early, and delayed based on risk category. Initial management is analgesia nitrates to relieve pain, dual antiplatelet therapy, anticoagulation, and then when the patient is discharged, we can give the patient nitrates, beta blockers, calcium channel blockers, antithrombotic, statins, ACE inhibitor, or ARBs. Very high risk needs immediate invasive strategy. For example, we should give PCI for this patient. Very high risk, which shows ongoing ischemia or hemodynamic instability. High risk, less than 24 hours, when there is elevated troponin, ST depression, and the patient has diabetes. Lower intermediate risk, we can delay invasive, or we can go for non-invasive. And when there's wake symptoms and non-diagnostic ECG. Complications are the same as ST elevated MI. Can be arrhythmias, acute heart failure, cardiogenic shock, recurrent ischemia, or papillary muscle rupture, or ventricular septal rupture, or any free wall rupture. When the patient has hypotension, pulmonary edema, or altered mental status, persistent chest pain, arrhythmias or tachycardic arrhythmias, or new murmur, they show deterioration. They are the red flags. We have to find these, we have to be aware of these red flags when we see any question. And the question stem, we have to check these. If any of these are there, then they are the red flags, and we have to be more cautious about it. Long-term follow-up is the same as other acute coronary syndrome patients. Smoking cessation is all about secondary prevention or complication prevention, like smoking cessation, like lipid lowering, like diabetes control, BP control, and things like that. These are the high yield testing points in MCCK1. A classic patient will be an old patient with risk factors, with just discomfort, which is similar to ischemic heart disease, but the patient has normal ECG or ST depression, ST segment or STT wave inversion in ECG. And also troponins are positive in blood testing. Some patients, like women, older adults, or diabetics may have atypical symptoms, but ECG will help us, and also troponins will help us diagnose this. When there is non-ST elevated or non-ST elevation in the ECG, we should not rule out an NST, non-ST elevated MI with one troponin. When one troponin is normal, we have to repeat it. We have to repeat ECG, we have to repeat troponin. CKMB is not the main diagnostic test when troponin is available, because troponin is more sensitive than CKMB. And because the ECG is non-diagnostic, we should not discharge the patient. The patient has symptoms, ECG is normal, we should not discharge the patient. We should admit the patient and then reevaluate the patient until we come up with the diagnosis. Next best steps in non-ST elevated MI. If ischemic symptoms are present, ECG. If ECG is non-diagnostic but suspicion remains, we should do serial ECGs and serial troponins. If troponin rises or symptoms recur, admit the patient, it will involve cardiology. And non-ST elevated MI is acute coronary syndrome without ST elevation. We confirm it with troponin. And this patient should not be sent home. This patient needs admission, monitoring, and risk-based cardiology care.